we're going to move on to our next panel, where we're actually going to focus now on lessons from the field. So we're going to hear from a range of speakers from across the region who have been developing and implementing digital mental health interventions over the past 12 months in response to the COVID-19 pandemic. We're very excited with the mix of speakers that we have, lots of different areas to hear about. I'm going to introduce our speakers very briefly as we move through the presentations, but please, you can have a look at the conference website where you can find their full bios and more information about everyone's work if you're interested. So I'm going to hand over to our first speaker. Our first speaker for the panel today is Professor Gan from the School of Psychological and Cognitive Sciences at Peking University. And she's going to be speaking today on the paradigm shift in clinical health psychology arising from COVID-19. So a warm welcome to you, Professor Gan.
Okay. Thank you very much for the introduction, and it is my great pleasure to be here to share some of my research and comments on lessons learned from COVID-19, and my title is Paradigm Change in Clinical and Health Psychology. So as we know, the outbreak of COVID-19 has induced panic, discrimination, and rumors, resulting in many mental health problems and social contradictions. And during this public crisis, the scarcity of psychological aid resources and the requirement of maintaining social distance make it very necessary to develop effective and accessible new intervention programs. Yes, sorry, I don't know whether my video has gone. And therefore, how to use the pandemic situation as an opportunity to promote paradigm change in this clinical and health psychology is a pressing issue. And my answer is that telemental health care service could be a potential solution to this issue. That is to develop a series of evidence-based, easily accessible, individualized, and low-intensity digital intervention programs that can greatly meet the diverse needs of the public. I think that a low-intensity digital intervention we have already talked and discussed in the previous sessions. So I'm just going to stress that this is only triggered by the pandemic, but it may also work after the pandemic. So that is a paradigm change. And this paradigm change I propose is in clinical and health psychology, aiming to establish a 3-level psychological assistance system comprising level 1 digital intervention. That is, majority of people can have that. And if that one is not effective, and we can go to the level 2, that is a telephone hotline service. Of course, this one is more individual, although it's intangible. And if this one also fails, we can only the minority of people can go to the level 3 system. That is a traditional psychological consultation, whether it's group or individual. So that actually helps to optimize the allocation of psychological service resources and alleviate the shortage of psychological assistance, especially in China. So in our team, we have developed more than 10 sets of low-intensity digital intervention packages. So that aims to eliminate the panic and discrimination, rumors, is doctor-patient relationship, and improve health behaviors. So I'm going to illustrate with two examples. That is the perspective taking training and the basic needs activity training. So this is a perspective taking training. We use an randomized control trial to confirm the effectiveness of that kind of training. So we all know that tension between doctors and patients have existed in China for a long time, and it still have not properly solved. Although COVID-19 may have improved this status a little bit, but still, like violence against doctors are often seen in the newspaper. So this has brought this doctor-patient conflict issue back to the forefront. And as an essential component of the doctor-patient relationship, we believe that trust actually is essential, and it can helps to build a harmonious relationship between doctors and patients. And perspective taking is a cognitive component of empathy, and it's a process of considering the world from the other person's viewpoints. That is, to put yourself into the other shoes and imagine other people's feelings and situations. So researchers have begun to pay attention to this central role of perspective taking in resolve intergroup conflicts for a long time. So I think this intervention can be used as a promising tool to enhance trust between doctors and patients. And this is an example we use in our RCT paradigm. And we let participants to read the following situation carefully and try to put yourself into that situation and imagine that you are a patient in this situation. And this is actually a very general format for presenting this kind of material. And the participants were required to write about 200 words about their feeling and their comments. And this is our result in RCT. We can see that in pre-test, post-test, and follow-up, and we have the dark ones as the intervention group and the light ones as the control group, and the interaction between group and the time was highly significant. And we can observe that the light bars actually who represent the control group remain non-significant in the intervention process. But for the intervention group, there is a significant increase in patient-doctor trust in the post-intervention, and it somehow retained persist in the follow-up. So the second example I'm going to give in is a basic need satisfying intervention that actually we aim at combating internet addiction during COVID-19, because you know that COVID-19 make people basically at home, so the internet addiction might be more may have more problem and harmful to people. So we based on self-determination theory proposed by Daisy and other scholars, and this theory asserts that people may have three basic needs: a sense of relationship, autonomy, and competence. But in a vulnerable environment like COVID-19, people have to stay at home and maintaining social distance. So this undermines all these three basic needs. So our intervention is to provide a self-supporting system to meet the psychological needs. So this is an example of our randomized control trial. And we selected young adults with the internet addiction score approximately at a subclinical level. And we, of course, we randomized the group and the control group, and we have a intervention for consecutive 10 days, and each day we have such a manual. And for example, on the second day, we want the participants to do something challenging, like make an untried dish. And this is something that you think is challenging. It's a little bit difficult, but can be done by you successfully. So after the 10 days, this is the result of our RCT. And we have seen that interaction again between group and time was significant. And we found that the blue bar, the yellow bar represents the control group, which does not change significantly. And the blue bar indicates the intervention group. And we can see a significant decrease here in retest, and a further decrease in post-test. And this intervention effect persists in the follow-up. So my comments actually at the lessons to learn is that in order to effectively use this kind of digital intervention, we have to assess the needs of the public. Some of them may seek help actively, but for the others who do not know that they need digital intervention, we have to give them individualized, tailored program, like in the precision medicine. So this is one, and this for this practice, I think a set of subjective and objective measurements need to be established. And last, I would like to see that COVID-19 is a threat, but a threat may mean it's a challenge. And for any challenge, there is an opportunity. So we hope that this opportunity will help our mental health service to grow and to serve more people. This is my comments and my sharing. And thank you very much for your attention. And this is my email address.
Thank you so much, Professor Gunn. That was a fascinating presentation, and I think a clear theme running through today's event is that really COVID has been quite an extraordinary opportunity. I just want to remind people, if you have questions for any of these speakers, you can start putting them into the Q&A box or the chat box, and you'll have an opportunity for those questions to be asked after this panel. So our next speaker is Professor Ren, who is a Professor of Clinical and Consulting Psychology at Central China Normal University. His presentation is on the application of digital psychological interventions during the pandemic and the development of a digital mental health service platform with the Ministry of Education in China. So thank you, Professor Ren.
So Professor Ren was not able to join us in person today, so he sent a pre-recorded lecture for us to share, which I'm sharing now.
Everyone, it's my pleasure to share our application of digital psychological intervention in major public health events. I will take an example of the MOE-CCNU mental health service platform. I want to introduce myself first. My name is Zhihong Ren, Professor of Clinical and Counseling Psychology in Central China Normal University. Considering the challenge and the risk of COVID-19 pandemic, we established a mental health service platform supported by Ministry of Education of the People's Republic of China. I am the head of counseling service of the platform. I referred it to platform in the following. My report includes 3 aspects: the construction process, basic situation and functional characteristics of the platform, the intervention process and effect of internet-based psychological assistance hotline platform, and the actor-based and self-guided digital intervention for depressed individuals. 4 psychological assistance hotlines were established for frontline medical staff, patients infected with COVID-19 and their families, public security officers and security personnel, overseas students and overseas Chinese, more than 4,000 qualified psychological consultants, and more than 1,200 universities and institutions have volunteered to provide psychological assistance, which means sufficient professional resources. And the psychological assistance work is not limited to run the psychological assistance hotline. Specifically, under the guidance of the leading group of the Ministry of Education for response to the epidemic, the Platform Management Group of the CCNU, Expert Steering Committee, Expert Working Group, Psychological Consulting Group, Platform Technical Support Group, and Publicity and Liaison Group jointly complete the publicity of the platform, consulting services, supervision and emergency response, daily information report, and political advice. In order to ensure the operation of psychological assistance work and the rights and interests of help seekers, as well as to optimize psychological assistance services, the platform has established a series of standards, including ethics codes of psychological consultation, supervision systems, training systems, and crisis intervention programs. The platform is based on the Tencent Cloud Contact Center as an omni-channel, omni-media psychological counseling platform. Our platform integrates hotline, WeChat account online, and audio and video calls supported by mini program and functions as the first comprehensive psychological counseling platform in China, with access to voice, text, artificial intelligence services. The platform covers 3 service objects, including the clients, professionals, and the public. From a technical point of view, the existing consulting platform is the integration of psychological consulting and intelligent media integration technology. The platform is oriented to clients and professionals exploring the cloud service model of soft resources and on the cloud of psychological counseling professionals to achieve precise and efficient matching of supply and demand. The second part, the intervention process and effect of internet-based psychological assistance. We also analyzed the problems faced by help seekers. In the first stage, as shown in the left picture, those seeking help from February 29th to July 3rd were mainly due to emotional problems caused by the epidemic isolation at home and their past experience, which accounted for 55% of all the problems. The senior students and students preparing for exams had obvious emotional problems, and some students lacked the motivation to learn online courses. International students cannot return to China, and they had emotional problems affected by the local epidemic. In the second stage, as shown in the right picture, from July 4th to September 29th, the emotional problems faced by help seekers increased, accounting for about 62.8% of all the problems they faced. Interpersonal relationship problems decreased, accounting for about 22.3%. Now, the third part, act-based and self-guided digital intervention for depressive mood. In the past 10 years, we have done a lot of work on digital psychological intervention. Our work is mainly focused on the study of the effect, matching, and mechanism of internet-based acceptance and commitment therapy in intervening depressive symptoms. The ACT Depression Self-Help Intervention is a self-help program based on the acceptance and commitment therapy, which aims to help users with mild to moderate depression to improve their emotions. The program uses mobile app as a platform for human-computer interaction and is based on ACT's psychological flexibility hexagon model, modularizes and computerizes the principles and methods of ACT, and utilizes media interaction methods such as audio, video, pictures, and dialogue to help users to achieve self-help emotional adjustment. The combination of artificial intelligence and psychological counseling is also the research direction I have been exploring. We developed this self-help intervention program for depression based on ACT. I will make a brief demonstration here. Self-help intervention program for depression based on ACT consists of 8 units, including a pilot film, separating from thoughts, accepting, focusing on the present, being one's own bystander, direction of life, commitment to action, and ending. The users can display the progress of the entire self-learning, check in and clock in the mood every day, and can see the mood changes of the clock in every day, and can take notes of what they learn in each chapter, and receive expansion exercises in each chapter. Take a look at the exercises in the acceptance unit. As the above-mentioned app innovation data is still being collected and cannot be reported now, we report here the results of our previous study on ACT intervention in depression to test the efficacy of the internet-based acceptance and commitment therapy, aka IACT treatment program. Compared with the WSE group, the IACT group showed significantly more relief of depressive symptoms and significantly better mental health, both at time 1 and time 2. The platform has achieved a series of results as follows. The platform has trained thousands of online psychological counselors and has served more than 80,000 help seekers. The positive rate of online psychological service by help seekers reaches 94%. The platform has also been commended by many administrative departments in China. We introduced the platform at the International Conference of the American Psychological Society. Thanks for your attention. That's all I shared. Please feel free to communicate with me.
Thanks for sharing the presentation, Brian. I imagine if you have questions, you can absolutely email those to Professor Ren after the panel today. So we'll move on to our next speaker, who is Professor Gina Hetanova. She's a professor and psychologist at Ateneo de Manila University, and she's also the chief of party of the USAID Renew Health Project. And she's going to be presenting for us today on the adaptation of a group-based resilience program in the Philippines. So over to you, Professor Hetanova.
Thank you. Hi, everyone. And thank you for the invitation to be here. So I'd like to just tell you a story about how we developed a resilience program. And we actually brought online a resilience program in the Philippines. my presentation today will consist of just a little bit about the needs analysis that we conducted, the development of a synchronous version of the program, and then the development of an asynchronous version of the program as well. So we did a brief survey between May to August last year to understand what mental health needs were needed to be addressed. And as you can see in this data, more than stress, it was really anxiety that people were grappling with the most. We also saw that was our youth that were the least okay. So they're the most stressed, they were the most anxious, they were the most depressed. And because they are also the digital natives, they were really the people that we wanted to reach out to. The data from that survey also showed us how important resilience was as a mediator between the stressors that they were experiencing and their mental health outcomes. However, we also saw how coping behaviors were quite important in predicting resilience. We know of adaptive coping behaviors, but in this particular pandemic, we found that some behaviors were actually more helpful than others. For example, in this sample, spiritual coping, acceptance, social support, people who did this reported greater resilience, but those who engaged in distraction actually reported less resilience. So given this, what we wanted to do is really to improve the adaptive coping skills and resilience of individuals. Last year, we brought to the digital platform a resilience program that we originally created in 2013 after the Super Typhoon Haiyan hit the Philippines. It was originally created as a face-to-face intervention. We conceptualized it as a focused, non-specialized intervention to be delivered by trained paraprofessionals. And it consisted of 6 modules. Strengths, focusing on managing physical reactions, managing negative thoughts, positive activities, seeking solutions and support, and meaning making and the future. Our theoretical foundations were positive psychology, cognitive behavioral therapy, and mindfulness. So we conceptualize these as resilience skills that can be developed if we just knew how. To deliver this using a digital platform was through what we call resilience classes. So it was like webinars, a Zoom class, which consisted of about 4 to 12 participants. And we would meet either once or twice a week for an hour and a half. And our facilitators were trained volunteers from the Psychological Association of the Philippines. So basically, we just transferred the face-to-face to an online platform, but did it similarly, almost in the same way. And we did find that adaptive coping behaviors increased significantly. And among our mental health outcomes, the direction was in the direction we expected, although the significant improvements were in well-being and anxiety. Now, because not everyone could get on to could dedicate the same hour and a half in the same day, in the same schedule, or some had internet difficulties, we decided to create an asynchronous version of it. So what we did is we created a class using Canvas, and basically we transferred it online we still had a facilitator, but this time our class sizes were much bigger, about 20 to 25. The inputs were provided using lecture videos, but we had discussion forums and exercises in the class site. What we did was we did a comparison of the synchronous and an asynchronous version. So we did sort of almost simultaneous, but not quite runs of it. And we found that across the groups, there were significant improvements in coping behaviors. And I put some stars into where there were significant differences. So improvements in active coping, emotional support, informational support, planning, reframing religion, venting, acceptance, and even humor. it was interesting that there was no interaction effect. So it didn't matter whether they were in the asynchronous class or the asynchronous class. Both groups had good improvements. However, there were some differences or nuances in outcomes. Okay, so in terms of the mental health outcomes, pre and post tests were significant for non-reactivity, resilience, and well-being. Although the mental health outcomes of stress, anxiety, and depression did go down as expected, they were not significant. We only actually found an interaction effect in non-reactivity. So non-reactivity is a subcomponent of mindfulness. So it's the ability to be aware of one's feelings, but not be necessarily overwhelmed by our negative emotions. So we are able to let it go. We found that those in the synchronous classes had a higher trajectory or improvement compared to the asynchronous classes. And we figured out why. Because in the synchronous classes, mindfulness was embedded as a centering exercise in all sessions. So people had to go through it, whether they liked it or not. But in the asynchronous classes, you could choose to just click forward or next, right? And not have to do it. So there's just much more practice in the asynchronous class. The effect size was large for the synchronous class, but small for the asynchronous class. But for resilience and well-being, the effect sizes were both large for both synchronous and asynchronous. So where are we now? We're actually trying to sort of develop the next phase of this, which is how to institutionalize the program. Now, all of this were developed without government funding. So this is all, a lot of it was just the spirit of volunteerism. We were able to get a small grant from our university eventually, but our main concern was who will deliver this. And I'd like you to understand that most of this is volunteer work. So none of us are getting paid to actually facilitate this program. So what we needed to do, as was mentioned earlier by our panelists, was how do you build the human resources capital for this? What we did recently was we created an internship program for the facilitators of the program through the Psychological Association of the Philippines. So we do have a lot of graduate school programs in psychology, many of which have practicum. So we're tapping them, the graduate students, and we make them now go through first the asynchronous program, and then we created an online course on facilitation. And the last phase of the internship program is their practicum. So right now we're launching the practicum stage. So they've already gone through the first sessions, their first training program. And starting next week, we will be launching 20 classes, resilience classes again, with our new facilitators. We still have older facilitators who will now be sort of mentoring and supervising them. What we're also trying to do differently in this next run of resilience classes, which will both be synchronous and asynchronous, we'll try for homogeneous groups. One of the things that we did before was just you could sign up based on a schedule. And we were having, a mixed group of mothers and teenagers and workers in one group. But what we imagined, and when we evaluated the program, we felt that maybe it might be more comfortable to try homogeneous groups. So that's what we're going to be doing next. We'll try it out and see if it will work better. We're waiting for funding to kick in to do a randomized controlled trial, hopefully this year as well. But other than that, one of the things that we'd like to do, so we're working with the USAID Renew Health Project and the Department of Health in now trying to see whether we can bring this to a mobile platform. So it's even more accessible for those without internet connection, so they can use their smartphones. I see Martin's here. You'll be happy that we got the consent of WHO to translate Doing What Matters Most in Times of Stress to Filipino as well, and to test that to see if that will work. We're also, again, in the interest of human resources, I'll be pilot testing an undergraduate course on psychological interventions in community settings next year. Again, this is also our way of making sure that we have enough people who can deliver these kinds of non-specialized interventions when we need them most. So there, thank you for your attention.
Thank you so much, Gina. That was fascinating. And I think it really reminds us of that, the importance of that iterative development process and building in the lessons learned, and also, I guess, the flexibility that digital platforms allow for being able to try and test new ways of delivering interventions. So thank you so much. I'm sure there'll be lots of questions for you after the panel. Okay, so our fourth speaker for this afternoon is Dr. Sarah Hetrick, who is presenting today alongside some of her colleagues, Dr. Nicola Luden and Sarah Bodner. They are from the University of Auckland. Dr. Hetrick is a clinical psychologist and associate professor in youth mental health in the Department of Psychological Medicine. And they're going to be talking today about their experiences developing and implementing a chatbot during COVID lockdown. So something that we haven't heard. We've heard a lot about different digital interventions today, but we haven't heard anything about chatbots yet. So very much looking forward to this discussion. Thank you so much, Sarah, and your colleagues.
Thank you, Cassie. Lovely to be part of the program and to be introduced by you. Sarah, Nicola and myself are going to provide an overview of the development of Aroha, a chatbot designed specifically for rangatahi. So that's our word for young people in New Zealand, Aotearoa, during the New Zealand COVID and related lockdown experience. So we'll describe the initial implementation, particularly how Aroha fits with the New Zealand government psychosocial response to the COVID pandemic, our current work and our plans for the future, particularly around increasing implementation and uptake of Aroha. So the first thing to highlight, I think, is that Aroha was developed to ensure responsiveness to Māori. So that's the Indigenous population in New Zealand. And importantly, especially for Māori, Aroha was designed with what we call whakapapa, which is sort of similar to genealogy. And that was in consultation with our kaumātua, our senior elder from in Māoridom, Rawiri Wharamata. And so Mātua Rawiri gifted Aroha's name, and Aroha means caring or compassion, which is what we wanted this chatbot to be for our young people. Aroha is also comprised of two words. So aro, the first part, is about turning towards, taking notice, paying attention and considering. And ha is about breath or essence. And as you hear a little bit about what's contained in Aroha, that will make even more sense. So Aroha was designed to provide some basic COVID-specific psychoeducation, as well as including and delivering therapeutically derived content to help with stress, anxiety and depression, and specifically though for young people. So this is a timeline of the onset of the experience of the pandemic and the initial lockdown in New Zealand. So it's really just to highlight our really rapid development and deployment of Aroha in that context. So New Zealand locked down the whole nation on the 23rd of March. And by the 7th of April, just over 2 weeks later, we had launched Aroha. Aroha we were able to do that rapid development because of our experience in the digital youth mental health field, and because the work that we were already engaged in when the pandemic hit meant that we had an existing digital infrastructure to be able to do that. So our team and various iterations of our team over time have developed a large number of digital tools, and going back a little while, that includes something called Sparks, which was an online gamified cognitive behavioural therapy intervention for young people with depression. That was tested in several randomised controlled trials and then was picked up by the New Zealand government and rolled out, and has been freely available in New Zealand since 2014. So on the basis of that experience, we've just grown and grown and grown. So we've been developing using co-design and agile development principles, working with Māori and Pacifica young people in a co-design context, partnering with academic and industry experts. We've been building this digital, what we call a digital ecosystem that provides a range of digital tools to support youth wellbeing. It includes Sparks. Sparks is there, you can see that down the bottom, but a range of new apps. And then, as Cassie said, more recently, we've been working on chatbots. So it's our current work in the area of providing chatbots that meant that we have in-house in-house digital infrastructure that enabled us to develop and deploy Aroha so quickly. So we disseminated Aroha initially on that 7th of April by a media release by one of our key funders, a Better Start National Science Challenge, through the Ministry of Business, Innovation and Employment, as well as we just emailed everybody. So we emailed directly to the Prime Minister's office, you can see her there, to the Ministry of Health Director General, that's Dr. Ashley Bloomfield there on the screen, the Deputy Director General, the Principal Advisor, and other key Ministry of Health officials that we already had relationships with. We emailed the Principals Association of New Zealand, so education principals in schools, as well as our own school and university networks and contacts. We emailed key mental health workforce organisations that we're all in contact with anyway in New Zealand and have significant reach to that key workforce. We emailed our suicide prevention coordinators, that's a specific workforce across the country in New Zealand. We emailed the New Zealand Health Promotion Agency, Te Herenga Hauora, and we emailed, of course, all our key academic collaborators across the country. So I'm going to hand over now to Nicola to talk you through some of the content and development.
Kia ora, Sarah. So here you can see an example of our Prime Minister, Jacinda Ardern, within the chatbot within Facebook Messenger. And here she gives a nice message of support, and the users can choose from a range of options to support mood and emotions, and this is to look at the PM's message. And so yeah, the message ends when she goes through a few things that she likes to do to help with stress, and it ends with informing users of 1737, which is New Zealand's national mental health helpline. So the next thing that we did was to look at some initial Aroha user data. So to begin with, we had 392 registrations and 238 logged into the. We had 127 in the target age range, these young people, 13 to 24. And demographically, we had about 70% female and 47% New Zealand European, but the remaining being Māori, Pacific, Asian, and other. And so of the average, on average, the target users engaged for around about 11 minutes, and 70% of the target age range users received all of the psychoeducation information. So within the Aroha chatbot, we also, it's also offered, practical support is offered, and of the optional activities offered after psychoeducation, the most popular, just based on completion, was calming, slow breathing. You've heard a little bit about that before, and general well-being, getting active, and spirituality. And so there are some other popular practical support modules as well, things like money worries and alcohol and drugs. And so we also, you can see the bubble there, We also took an anxiety score at the beginning of the chat with Aroha and at the end of the first session. And even though we sort of had low completion of around 37% of both of those, the indication was that we're not doing any harm, and the mean anxiety score at the beginning was 5.1 and reduced to 4.3 at the end. So one really important thing that we have been doing as well is getting feedback from young people who have used the Aroha chatbot. So you can see here some of their comments that came back to us. So it felt like having a casual conversation rather than being lectured to. And I liked how Aroha used language that I use to communicate, like heaps or a lot, and whānau, which means family, easy to talk to and engage with. The tips she gave around how to reduce stress were useful. And so getting feedback is really important, to inform the direction of the chatbot, and it's allowed us to incorporate things that our young people are really looking for. So here you can see that Aroha was part of the digital aspect, as we've heard of the Ministry of Health psychosocial response across the country. And there were a range of digital tools that were funded, released and endorsed. And importantly, we had visibility on the Facebook page here. And Aroha was the youth-specific digital tool in that suite, and we received just some short-term funding on that basis. So on the back of the feedback, together with the strong Ministry of Health buy-in and engagement, we've been able to develop the content and the usability of Aroha, which is now allowing us to make the chatbot more conversational and more interactive. And one of these important things is to include more te reo Māori language content. And this has been led primarily by Tanya Cargo on the team, who is well known in the Māori child and adolescent mental health setting, and also Kiani Stevenson, one of our younger researchers on the team, doing very well there. So thanks very much. And I'd now like to hand over to Sarah Bodmer.
Kia ora. So I'll speak a bit to what we're looking to do in the future. Our plan now is to increase the use of te reo Māori into Aroha, as well as incorporate Indigenous health philosophies such as hauora and maramataka. Hauora in particular is a holistic view of health held by Māori, which encompasses physical, mental, social, and spiritual aspects of health. Incorporating this holistic view is essential for us to address well-being in a way that is meaningful for Māori. And we sort of believe that by doing this, it's actually going to be meaningful for all New Zealanders. The biggest challenge we face now is actually just reaching young people and having the target audience use and engage with Aroha. Our strategy to overcome this is to bring Aroha to where the young people are, and we know that this is online. We know that young people spend a significant amount of their time on social media, and this is a contributing factor to why we chose to launch Aroha through Facebook Messenger. Aroha is now also on Instagram and Facebook, and that's really with the goal of reaching these young people and bringing Aroha to them. We're also working alongside local schools to implement Aroha, as well as our other habits tools. By nature, social media is adaptable, quick, and keeps up with trends. By utilizing social media, we're aiming to keep Aroha relevant to young people. For example, when the recent earthquakes occurred in New Zealand, we were able to share content which aimed to support young people who found them distressing.
Great, so thank you, Nicola and Sarah. It's been great to be able to share not just about Aroha, but to introduce you to some of the large team that works on this. I think that's been mentioned in the talks. It's always a multidisciplinary approach to these things. And yeah, thanks for just engaging with us around this.
Thank you so much, Sarah, and all of you. That was great, and always extraordinary to me how quickly you were able to get that chatbot up. Really amazing work, and it's very exciting to think about where it might go in the future. So our last speaker for today is Dr. Jean Liu. She's an assistant professor of psychology at Yale NUS College in Singapore. And she's going to be presenting for us on the Singapore government's use of WhatsApp to combat COVID-19 infodemic through rapid transmission of accurate health information. So thank you so much for being here, Dr. Liu, and I'll hand over to you now. Thanks.
Thanks, Cassie. The approach that I'm going to present today is slightly different from the conventional and the talks that have come before me. So it's been really interesting to hear what other people have to share. So our work started with an observation that if you take all the meta-analysis of what are the risk factors for poor mental health during COVID-19, you get your normal demographic variables emerging, gender, age, marital status, education, and so forth. And then, a couple of pandemic-related factors have emerged: quarantine status, COVID-19 diagnosis, whether someone is experiencing physical symptoms. Perception of the situation seems to be having a very big role. So, for example, if you think that you're feeling lonely, if you think that your health is bad, you're more likely to experience poor mental health. But what really puzzled us was, or really what intrigued us, was this seemingly modifiable set of risk factors. So two in particular: exposure to COVID-19 news and exposure to misinformation, that again and again in multiple studies have been emerging as risk factors for poor mental health. So the first thing that we did was to say, to ask some background research. We said, where are Singaporeans getting their COVID-19 news from? So this isn't very surprising. Like many countries in the world, our top source is a news website, but following very closely, you can see over here, WhatsApp has emerged as a very major source of COVID-19 news. We then ran a daily diary study where we tracked people's WhatsApp use every day for 1 week. And during 1 week of monitoring, you can see nearly every participant recorded at least one use of WhatsApp for COVID-19 content. And then the related question we wanted to ask, how prevalent is misinformation? So we picked a couple of the common COVID-19 rumors, many of which are addressed in the WHO website. So for example, does drinking water help to prevent COVID-19? And as you can see over here, nearly every participant had heard COVID-19 rumors, with a median of 3 rumors they had heard out of the 5. And again, rumors were largely encountered through WhatsApp and Facebook. So then we asked, can we bolster mental health by addressing news sources? So in the now well-quoted quote from the Director General, we're not just fighting an epidemic, we're fighting an infodemic. Can addressing that infodemic then bolster mental health? And in particular, we were very fascinated, based on all the background research we had done to this point, with this new WhatsApp subscription for COVID-19 news that has been rolled out by the WHO, by the UK government, by the Australian government, by the Singapore government, and quite a lot of other governments as well. WhatsApp has certain advantages. The first is access. Is the most widely used messaging app used by 2 billion users in 180 countries. And it's very fast. So you can send out messages almost near instantly, and it's used, you can send it out on the very platform that rumors are disseminated. So we're very, very interested in whether this would, subscribing to a service like that can make a difference for mental health. So nicely enough, we are located in a place where we have a natural experiment to evaluate this. So from the start of the pandemic, around January, Singapore rolled out a subscription-based WhatsApp channel. So you go on the gov.sg website and you subscribe for this WhatsApp channel. It's available in Singapore's 4 primary languages, so it's nicely translated. Twice a day, you get updates on the local situation. So it ranges from confirmed cases, how many new cases there are, debunking rumors. So the Prime Minister is not addressing the nation and Singapore is not going on lockdown tonight, okay? Disseminating knowledge. So every time there's new research, the gov.sg platform will send it out. New infection control measures, all sports and recreation facilities will be closed. Economics and social support the government is rolling out, and responding to all kinds of ad hoc events on the ground, like don't panic buy right now. So here's a sample of a WhatsApp message. So as you can see, it's all in point form. Okay, very short, punchy sentences, use of bold text. And what fascinated a lot of people was the government was sending them emoticons like this. Similar to the app we just, to the chatbot we just saw in a casual kind of language. Nicely enough, by March, 2 months after it was rolled out, it was adopted by 1 in 10 residents. So that's quite a large number, and that provided a natural experiment to evaluate its impact. So what we did was between March to April 2020, so that covered a lockdown in Singapore, we ran a cross-sectional survey of about 1,000 Singapore-based adults. We ran the depression, anxiety, and stress scale. So as many of you know, there's a depression subscale, an anxiety subscale, and the stress subscale. And as the key predictors of their scores, we of course asked about their use of the WhatsApp channel. You subscribe to it. But we also asked more broadly about the exposure to COVID-19 news and also control for demographics. So can we bolster mental health by addressing news sources? First, we replicated the very robust effect that COVID-19 news exposure did indeed predict poorer mental health. So if you spend more time getting COVID-19 updates, you had higher depression, anxiety, and stress scores. If you had more exposure, or you ended up sharing or hearing or believing in more COVID-19 rumors, you also had more anxiety. And so the $1 million question is, but however, having control for news exposure, okay, use of the official WhatsApp source emerged as a protective factor. So you can see over here, users of the official WhatsApp channel, okay, had decrease depression scores, and the DAS21. So these are log scores, and if you trusted the official messaging on the WhatsApp channel, then you had decreased anxiety scores as well. So this is fairly robust. So all these effects that I've just reported was true even if you corrected or did not control for the demographics. So in short, can an official WhatsApp channel boost mental health? This is a fairly new area since social media research in the pandemic is only preceded by Ebola and Zika research, as you can see in these studies. And there's not much research evaluating things like this WhatsApp dissemination of news. And notably, even our study was not an RCT because it's quite difficult to evaluate that. So what we present is preliminary evidence, but it's quite promising as a public health intervention for several reasons. First, it's very cheap. We've been talking a lot about staffing needs of counseling hotlines or services that we provide online. Well, this is not labor intensive at all. Also, because of the sheer base of WhatsApp subscribers in general, this can reach a large sector of the population across various demographic backgrounds. And in many senses, you would roll out a WhatsApp service anyway to help in risk communication. So this is just a side benefit of that. So I want to end off with just a couple of acknowledgements. So this is my collaborator, Eddie Tong, and then my lab members. If you want to follow our lab research or find any of those papers, you can find us there. Okay.
Thank you so much. That was a beautifully succinct presentation. Perfect, given that we're running over, and I want to make sure that we've got lots of time for everyone to ask questions. Thank you so much to all the presenters in the panel. It's been exceptionally interesting. I'm hoping that we have lots and lots of questions. Please, all of you who are listening, if you have questions for the presenters, put them in the chat box now or in the Q&A box. I'm going to hand over to my colleague, Dr. Jason Liggett, who is going to moderate the final session. Thank you all.